Hello, everyone. I'm Nicole Moore. I'm a continuing education coordinator for the Collaborative for Accountability and Improvement. We have a special webinar for you today, hosted by both CAI and the PACT Leadership and Innovation Network DEI work group. Before I hand it over to our speakers, I wanted to share a couple of housekeeping items. First, the webinar will be recorded and available on the CAI YouTube channel next week, so please share this session with your colleagues. Second, please feel free to put questions into the chat at any time. We will address your questions during specific sections of the presentation. I will now hand it over to Tom Gallagher, Executive Director of CAI and a professor in the Department of Medicine at the University of Washington, where he is Associate Chair for Patient Care Quality, Safety, and Value. He is also a professor in the Department of Bioethics and Humanities. Thank you, Tom.
Thanks so much, Nicole. And it's a happy Halloween to all. I hope you're having a good day, and we're thrilled that each of you is here with us to talk about this challenging issue of how can communication and resolution programs function effectively when it comes to supporting historically marginalized patients and families who have experienced a harm event. I'm here with two of my colleagues, Dr. Stefan Pearlman, who is the medical director of the Candor program at ChristianaCare, and Emmanuel Opati, who leads a lot of the communication and resolution program work that's taking place at Johns Hopkins Hospital. The objectives for our time together are on the next slide. We want to describe the challenges that historically marginalized patients can experience during the CRP process. We'll be using two hypothetical cases to highlight the practical ways that these challenges can manifest themselves. And then we'll be identifying some practical strategies to improve the ability of communication and resolution programs to support historically marginalized patients and their families after harm events. We have a lot to cover in a brief period of time. I'll provide an introduction. Stefan will talk a little bit about some of the data that they've been collecting and looking at around how do the candor and non-candor cases in marginalized patient populations play out at ChristianaCare. As all of you know, data is integral to the development of highly reliable communication and resolution programs. So hats off to ChristianaCare for collecting and sharing this data. I'll take a few minutes then to talk about some of the challenges that historically marginalized patients populations can experience during the CRP process, and then we'll dive into our two hypothetical cases. Emmanuel will talk about a case that highlights some of the challenges that can occur early in the CRP process, and Stefan will talk about challenges that can manifest themselves later in the CRP process. Throughout, I hope all of you will be thinking carefully about some of the strategies that can be used to improve CRPs for historically marginalized patients and some of your takeaways and lessons learned, because at the end of the webinar, we'll be hoping that you can contribute in chat what are some of the strategies that you think could work at your organization and what are some of the lessons learned for you. And we'll be working on that content together. And then hopefully we'll have a few minutes at the end for questions and answers. Well, just a little bit of background. We know that historically marginalized patients are more likely to experience problems in their care, and they're less likely to experience a satisfactory response. It's really a double whammy. Each step of the CRP process, whether it comes to event identification, all the way through communication with patients and families, event analysis, resolution, can be more challenging when that harm event involves a historically marginalized patient. And I would assert that how an organization responds when there's a harm event involving a historically marginalized patient can represent a stress test of sorts. both for the organization's commitment to improving healthcare equity, but also it's a really wonderful stress test of the reliability of their CRP processes. How are we using the term historically marginalized? On the next slide, we lay out some of the categories that for the purpose of this discussion, we're using when we mean historically marginalized. And they include race, Black, African American, American Indian / Alaskan Native, ethnicity, Hispanic, Latino, or Latinx, English proficiency, needing an interpreter for any language, and insurance status for Medicaid and uninsured. And this is the definition of historically marginalized we're using in several current research projects on this topic. But it's important to acknowledge that there are many other extremely important categories of historically marginalized patients that are not included in the above. And we should also be thinking carefully about age, about gender, about sexual orientation, and a whole host of other categories may make patients at higher risk for having a harm event and also at risk of the CRP process not going well. So with that, let me pass things over to Stefan for just a moment to share some of what they're learning at ChristianaCare about how historically marginalized patients experience candor and non-candor cases at their organization. Stefan?
Well, thank you, Tom. And it's my pleasure to be here today to talk on this topic. Obviously, organizations have begun to collect data regarding a lot of the DEI issues. It's sort of a requirement these days. So I hope your organization is getting on with that work. ChristianaCare has had a candor program since 2015. And being that we define things as a candor case as one involving either death or permanent harm, we've evaluated over 600 cases since then, and about 2/3 of them are due to unexpected death. And those were the ones that we focused on because it was easier to find a comparison group. So I wanted to look at, our team wanted to look at DEI issues in this population of candor patients who experienced unexpected death and to create a comparison group of patients that experienced death but not a candor event during the same time period. And we excluded mothers and babies from this analysis. And what you're going to see are some initial results of our univariate analysis, but a multivariate analysis is in progress at this time. Next slide, please. So what you see here on the left-hand side are the candor patients that experienced death. There are 237 of those. And during the same time period, over 8,000 patients who experienced death that were not candor patients. And we compared them in this univariate analysis with regard to a number of different factors. So in terms of age, the patients who experienced a candor event, meaning it was an unexpected death, were younger. They were 6 years younger on average. And that's probably a reflection of the fact because they were younger, their death was less expected. They were more often Black, 39% versus 24%, and that's consistent with what Tom mentioned just a few minutes ago about marginalized populations. We did not find a difference with regard to Hispanic ethnicity between the two groups. We looked at a composite of Medicare and Medicaid, and the patients who were not candor patients were more likely to be on Medicare or Medicaid, and this may be a reflection of the fact that the non-candor population was older. There were no differences in gender between the two groups, and we looked at something called the Elixhauser comorbidity count, which includes 30 different diseases that patients may have that may put them at higher risk, and it's not weighted in any way. And interestingly, the candor patients did have a higher rate of these comorbidities. However, when we looked at expected mortality between the two groups, the group that were the non-candor patients were far more likely to have an expected mortality than the patients in the candor group. The last thing we looked at, or the last thing I'm going to report to you on, is the area of deprivation index. And this is measured by the patient's address, where they live. Interestingly, we did not find, I couldn't put all the results because it is a 10-point scale and pretty complicated, but suffice it to say that we did not find any statistically significant difference based on where our patients lived. So that's what our preliminary data shows, and we're going to move this analysis forward and hopefully learn more about the differences between these groups. Tom?
It's so helpful. It's so helpful, Stefan. And what does the data at your organization show? I hope all of you are following Christiana Care's lead and starting to collect and look at some of this data. So let's talk some about what are some of the challenges, first, that historically marginalized patients can experience, and then we'll talk about some of the challenges that organizations can experience when trying to use the CRP process for historically marginalized patients. Obviously, the crux of this involves disparities in healthcare outcomes, well documented in many different domains. But historically marginalized patients are more likely to experience worse healthcare outcomes overall, and more likely to experience problems in their care. Historically marginalized patients are likely to encounter healthcare workers and systems that are not sufficiently skilled in culturally competent care. We know historically marginalized patients have lower trust in healthcare overall, as well as in healthcare providers. Unfortunately, historically marginalized patients, we think, generally are less likely to speak up when they think something has not gone well in their care. Although I will show you some data in a minute that points out how complicated some of these issues are and how they relate to our expectations for what high quality care looks like. The patients on the receiving end of the CRP process may experience challenges where information about the harm event is shared in ways that are difficult to understand. And for patients who have a situation that involves potential financial or non-financial resolution, it can be difficult for historically marginalized patients to secure appropriate legal representation. And as we go along, it will be great to hear from you as we think about the cases. What are some of the other challenges you think historically marginalized patients can experience? We want to share as much data as we can with you, so I thought it would be interesting for you to see some data from a study we did with colleagues at the MedStar Health System. We surveyed over 10,000 patients after their discharge from the MedStar Health System. And one of the questions we asked was, do you think you experienced a problem in your care? A second question for those respondents who said they had experienced a problem, we asked, did you feel comfortable speaking up about the problem? And broke it down into patients who said they were not always comfortable versus the patients who said they were always comfortable. And Nicole, if you can click on the next animation, I was very interested and a little bit surprised to see the data here. So if you look at the bottom left, when you compare white versus African American, you'll actually see that African American patients were slightly less likely to report having experienced a problem in their care. 50% of the white patients said they experienced a problem. 46.8% of the African American patients reported experiencing a problem. And given the very large sample size here, that difference is statistically significant. Same thing is true if you look at the far right column. 68.9% of the white patients said that they always felt comfortable speaking up if they experienced a problem, but a slightly higher percentage of the African American patients reported always being comfortable, a difference that was statistically significant. It shows you how complex these issues are. And when I ask some of my colleagues who are experts in caring for historically marginalized patients and research in this area, this was not surprising to them at all. They said this all reflects the fact that historically marginalized patients may have lower expectations for what high quality care looks like, and so may be less likely to identify a particular event in their healthcare as representing a problem compared with the non-historically marginalized patients. So this is a complicated area, and keep this issue of expectations in mind as you hear about the two cases we're going to present momentarily. But the challenges are not just at the level of the patient. Healthcare organizations also can experience challenges when attempting to use the CRP process for historically marginalized patients. It can be difficult acquiring accurate data to identify who are our historically marginalized patients. It can be difficult to overcome a long history of discrimination in healthcare. The first 7 years, I did my residency, and then the first 7 years of my faculty career were at Barnes Jewish Hospital at Washington University in St. Louis. Wonderful organization, but until I think the mid-60s, it had a Black ward in the hospital, which was in the basement where radiation therapy was. Many of my clinic patients remembered the fact that Barnes Hospital had a Black ward. And you can imagine what impact that had on the way they interfaced with healthcare. It can be difficult for healthcare organizations to build trust, especially when something has gone wrong. Some historically marginalized patients, it may be difficult to physically communicate with. They may not have a cell phone or a computer or other ways that we can reach out and communicate with them. We mentioned on the earlier slide, patients can be recipients of culturally incompetent care, and that's a reflection of healthcare organizations and providers having difficulty behaving in culturally competent ways. One of the biggest challenges in this area, a highly reliable communication and resolution program, is proactive. And for historically marginalized patients, I think there's more of a tendency to just sort of sit back after a harm event and see, is the patient going to say something? And that lack of proactivity can be a real problem. And then there can be circumstances where finding interpreters for rare languages can present a problem. Well, we want to get into some specifics, and Emmanuel will first share with us a fictionalized case based on real circumstances that illustrates some of the challenges early in the CRP process. And then Stefan will share a case, also a fictional case, depicting some of the challenges that happen later in the process. Emmanuel?
Thank you, Dr. Gallagher, for that overview. Good afternoon again. My name is Emmanuel Opati. I do manage the CRP program here at the Johns Hopkins Hospital. Our first hypothetical case, next slide, please. Again, disclaimer, this is a hypothetical case, and any similarities with a real case is purely coincidental. Next slide, please. So our first hypothetical case is a 50-day-old female patient that was transferred to our NICU from another pediatric emergency department. Patient had been diagnosed with hypovolemic shock prior to being transferred to our NICU. Patient was admitted to our NICU, hydrated, stabilized, and then transferred to the floor, although with continued diarrhea. Patient became tachycardic with sunken fontanelle, and the plan was to initiate IV fluids, but access was difficult throughout the day. So the plan then shifted to giving Pedialyte via a nasogastric tube. And then later that evening, patient deteriorated, rapid response team was called due to poor perfusion, no detectable pulses, and CPR was initiated. Patient was then transferred to the PICU with continued CPR and placed on ECMO. Patient expired, and this was reported as a sentinel event. Next slide, please. So why was this a CRP case? It was determined that there was delayed recognition of the severity of the clinical deterioration from hydration due to appreciation of severity of patient abnormal findings, including weight loss, sunken fentanyl, high volume of oral intake. There was also a lack of objective data available to the team, including daily labs and accurate intake and output data. There was delayed treatment of hydration, as you saw, due to lack of escalation to alternate options after failed attempts to obtaining the IV access. In our process, we do ask these three questions. Was standard of care met? In this case, the answer is no. Was there significant harm? Yes. Was harm caused by lapse in standard of care? Yes. Next slide, please. So this slide outlines the CRP framework that we use. This is the ideal case scenario. Event identification where needed, just-in-time coaching. There's disclosure and assigning patient relations contact. Event review and investigation is done. There's support for the clinical team. There's support for the patient and family. The findings are reported as well as the lessons learned. We also share those findings and system changes with the family and the patient. We do have a resolution meeting, and the framework calls for the post-event patient engagement. Next slide, please. So for this case, we put it through this process. So there was disclosure, there was a team debrief, the RC was done and finalized, and then our patient relations team started working on scheduling meetings with the family. Patient relations reached out, and the mom reported that she did not want to meet and talk. Patient relations reached out again. Mom had questions. The good thing with the process is that when patient relations reaches out to these families, they leave the contact number and email. So mom called back to confirm that she would attend the resolution meeting. But then the family requested for an autopsy report, which was later sent. There was a resolution meeting and the case was resolved. So the red here is to highlight that the biggest challenge with this case was scheduling the first meeting with the family. As you saw, mom mentioned that she did not think a meeting was necessary and that she did not want to reopen grief for her, her husband, and her child. However, she said she was at peace, but if there was any new information, she would reconsider meeting with us. Next slide, please. So some of the practical takeaways from this case is that culturally competent teams are really critical. Our patient relations team knew that this was an immigrant family and had to proactively reach out. The other was acknowledging and addressing the fears and misunderstandings that some of these families may have. Because if you don't do that, that will likely hinder the effectiveness of the CRP program. What other one practical takeaway is no one size fits all. CRP programs should use culturally competent teams and also be mindful to individualize approaches to effectively address these diverse patient populations. It's also helpful to share somewhat of a roadmap of the process, especially regarding what the endpoint looks like, to help keep the engagement with the patient and the family.
So, Emmanuel, thank you for sharing that case, and we'll have time to talk a little bit more about it during the question and answer. But do you have thoughts about why the mom, beyond just she didn't want to reopen grief, do you think there were other barriers that were leading her or the rest of the family to not engage? And any ideas about why that changed?
Yes, so there was another point, which is that the dad was on a wait list for an organ transplant, and the family was very hesitant to engage because they did not want to do anything that would jeopardize that process. So that was another factor here, and we had to make them comfortable that it will not.
So keep going with that for just a minute. In this hypothetical case, it sounds like there was concern within the family about sort of raising their hand and expressing concern and its impact on one of the other family members' care for a critical illness. Is that right?
Correct.
Really complicated and interesting, and I'm glad. Do you have any thoughts in this case about, in addition to the outreach from the patient relations team, were there specific ways that they reached out that helped build some of that trust? And did the family express their concern directly about impact on the husband's transplant status, or did that come out later?
So that did not initially come out. So as you saw in that process, in the framework, there were multiple attempts until I think it was the third attempt that it came out. And that's the fear that they had. And that's what they're saying, they're at peace with it. But until we had to address that, they were very hesitant to engage through the process. And CRP calls for engagement with the family because we typically do we reach out twice. If we don't hear from the family of the patient, we'll likely send a letter and close the case. But as you see here in this case, this was a different kind of family and we could not follow that process.
Thank you so much for sharing that case. And I hope all of you are thinking hard about, in addition to some of the strategies Emmanuel shared, what additional things could be used to support a patient or family in a challenging situation like this. Let's move on to our second case, which presents a hypothetical challenge that occurs late in the CRP process. And Stefan, do you mind sharing that with us?
Not at all, Tom. Thank you. I will say that as a former or reformed neonatologist, that hypothetical case sends chills up and down my spine. But I'll also say that I think one of the things the hypothetical case illustrates to us is that, if you keep at it, you can get to the end point. And I know that there have been cases that we've done a thorough evaluation of and made a determination similar to the hypothetical case that, we owed the family some compensation, and we have not been able to get some of those people to come back for a variety of reasons. So, I think the example that Emmanuel gave shows that you have to be persistent. So we'll go on to the next slide. Very different kind of case. And again, this is a hypothetical case. The patient is a 45-year-old Latino male who has limited English proficiency. And he was admitted to the hospital for a cholecystectomy, a robotic cholecystectomy. And an IV was placed for the intraoperative fluids that he needed, antibiotics, anesthetic agents. And as it's typical for those of you who have ever seen robotic surgery, the arms of the patient are not splayed out the way they are in conventional surgery, because that inhibits the ability of the robotic arm to get into position to do the procedure properly, or the person who's controlling the robot. So the arms are covered and they are tucked at the patient's side, which is standard for this type of surgery. And at the conclusion of the case, which went very well, the arm was found to be swollen, blistered, and the patient's hand was cyanotic. There was a decreased pulse in that arm. And, this is interesting because nobody suspected that there was a problem with this IV, because it continued to function well in terms of the patient responded to various medications that were given through this IV during the procedure. And so based on what the findings were postoperatively, the patient was diagnosed with compartment syndrome, and an emergency fasciotomy was performed on the patient. Next slide, please. So when the patient woke up, the people involved in this case disclosed to the patient through the use of an interpreter, which was a little bit challenging because even though he was Latino, he spoke a particular dialect of Spanish, so it was a little bit hard to understand. Explained, that this complication had occurred and that we were going to perform a review. And although the patient understood what happened, he was a little bit confused by the idea that we were going to review this. And I don't know about all of you out there, but we've had this experience before with patients from other cultures wherever they came from, that if something like this happened, nobody would ever have performed any sort of analysis of it. So we did a root cause analysis on this case, and it was determined that because we had the inability to observe the arm during the robotic procedure, that this is why it occurred. And as a result, we learned and we were able to put certain mitigation strategies in place to prevent it from happening again. So even while we were going through the root cause analysis, the patient had ongoing needs because he had pain and weakness even after the fasciotomy to release the pressure on his arm. So he needed physical therapy and occupational therapy. And so the hospital offered to provide these services at one of our facilities, and obviously that we would, be paying for those services to occur. He was called on a number of occasions by our patient relations department, but again, communication was challenging due to his particular dialect of Spanish. And because the patient lived quite a distance from the hospital and didn't have a good transportation, he was really not able to get the therapy that he needed, which was very unfortunate. And he was also not able to return to the hospital for the final disclosure meeting. So we really ran into more problems later on in our process compared to Emmanuel's case. And it was challenging. Next slide, please. I think this goes back to Emmanuel now.
Thank you, Stefan. So challenges the family faced during the CRP process. I'll go through it quickly because I know Dr. Gallagher has, at the end, a slide collecting some feedback from the group. So language barrier. So the first hypothetical case you saw, they were immigrants, obviously English as a second language, understanding their rights, medical terminology, CRP process is challenging. Cultural barrier and health stress. We talked about, the stress they had in the family. This mom was caring for a young child. Another parent had a complicated medical issue they were dealing with. And underlying all of that is deference to authority, not questioning medical authority. Then health literacy, limited understanding of the healthcare system generally left them vulnerable. And to the point that they were just accepting the situation as it is, and could not believe that harm would happen at a large institution. Next slide. Back to you,
So related to case number 2, I posed some questions as well, which is, was there a different way that the communication issues could have been approached? Within your CRP and your hospital, how would you have dealt with the transportation issue? Would you have provided transportation to the patient? Or would you have allowed the patient to get therapy somewhere that was closer to their home, even though that would have been at a greater cost to the institution? Would you have held a final disclosure meeting remotely, assuming that the patient had the means to have that discussion remotely? I know within my institution, there's reluctance to do that. We prefer these to be in-person meetings. So again, perhaps that could be accomplished through providing the patient transportation to the hospital. And, as a health system, should there be an upper limit on what we're willing to do for a patient that has experienced harm? In other words, once we got through this PT and OT, if the patients claimed other healthcare needs, would we have continued to support that? So those are some of the questions that this hypothetical case brings up in my mind.
Thanks to you both for sharing that. And what I'd like to do, we have 20 minutes to have some conversation and to think about some strategies. But first, if folks have any questions or comments on hypothetical case 1 that Emmanuel shared, please enter them into chat. And then we'll take a few minutes to see if folks have any questions about case number 2. So I think, Michael, your question, and Stefan, you can see our friend Boris entered a question about how is candor defined at Christiana Care. And it looks like this is a question, Michael's question and Boris's is related to case 2, if I'm correct. So let's pause for just a minute and see any questions, clarifying questions for Emmanuel about case number 1. Just throw those into chat and we'll give Emmanuel a moment to respond. And Linda, I see you have your hand raised. If you have a question related to either case 1 or case 2, just put that right into the chat.
So I'll ask Emmanuel a question. You know, do you think that, and I'm speaking from, from my own experiences, do you think that we do a good enough job of explaining our process to people on the front end? Do you think they understand the purpose of all this well enough?
That's a fantastic question. Because we do want to be upfront with disclosure, at that point of disclosure, we don't have as much information because remember, there's no RCA yet. So there's only so much you can talk about that you actually know. So that leaves us in this situation whereby the initial disclosure does not obviously lay out what the framework of a case ends up being a CRP case. So to answer your question, it's hard to do it upfront just because just happened and you want to disclose and you want to be upfront with the family, and it's hard to tell them what process that event will go through.
So Kathy notes, I've also experienced patients' lack of interest in participating because they fear it might impact future care. So Emmanuel, can you say a little bit more? It sounds like due to the skillful communication from patient and family relations, this concern ultimately surfaced. What do you think it was that allowed the concern to surface? And when it did surface, how do you know how patient and family relations responded?
Yeah, so one is patient relations office contact made sure they're clear about the 2 processes. One is this CRP case, and what we know after the RCA and after knowing what our CRP process should be, that this case will not impact their future care in any way. Once that separation was made, they were able to think about this in a different way, and us obviously apologizing about what happened does create trust. Obviously communicating empathetically also does create trust. It's really hard to replicate that. I can't say that you can take that and just replicate it with another patient, but it happened that our patient relations contact is a female and was talking to a mother. She's African American. This mom was African Black. So I think there was some connection that happened there, but this is a real issue in terms of engaging patients.
And Emmanuel, you might have noticed the question from Ashling around how this organization hypothetically would have thought about proactively covering some expenses like funeral expenses or lost wages, which are real expenses this family experienced as this process was unfolding, covering those in real time while the investigation was taking place, or does your organization typically wait until the investigation is concluded to think about covering some of those costs?
There are some resource recovery things that can be done while the investigation is happening. But typically, if it's a CRP case that is going to be resolved with compensation, the process has to be done. That's why engagement with the family is key. And for this case, this hypothetical case, the way it was resolved, it was actually resolved moderately quickly with compensation. So it did not drag out too long for the family.
And thank you. And Michael, Lloyd has a great comment about perhaps creating a document that can summarize the CRP process for patients and families. And if Nicole or Melissa are able to, there are actually several patient-facing documents that have been created as part of the PACT collaborative to help patients and families understand the CRP process. I think there's a lot of opportunity for thinking about ensuring that those documents are as culturally competent as humanly possible for different patient populations. And we've not had the sort of the bandwidth or resources yet to think about translating those into different languages, but there are those documents that you can start with.
Yeah,
Stefan,
I was going
go
to
ahead.
talk about that too, in terms of the toolkit, because there are, examples of patient-facing documents that we have utilized, and we are actually in the stage of updating our communication that is patient-facing, and also having it available in Spanish as well. Michael also asked the question, would we consider having the disclosure group go to the patient for the meeting? That's a great question. We have been, very innovative at times trying to meet the patients where they are. So I have actually gone to a rehab, nursing home type of facility, a skilled nursing facility to meet with a patient together with patient relations. But very often we have, several physicians involved. We usually have a nursing representative involved that takes part in the final disclosure meeting with the family. And sometimes the logistics of that make that very challenging. And I'll just very quickly answer Boris's question. The non-candor patients were patients that died at the hospital during the same time period as the candor patients, but were not identified as an unexpected death. So I hope that helps.
Yeah, and Stefan, also see the comment that Boris just added about case 2. I think it's very insightful. Sort of, I'm sure finding an interpreter who spoke this patient's specific dialect is it may have been challenging, if not impossible. But I think Boris is pointing out something really important, which is oftentimes we sort of get by. We think we're going to get as close as we can. We'll have a Spanish interpreter, even though it's not perfect, or there's a family member in the room who's interpreting. Not great, but it's the best that we can do in this case. And I think that oftentimes is a disservice. We can actually, and I'm not implying that this organization didn't try hard enough in this hypothetical case, but how did you think about, was there a way to bridge this language gap?
Yeah, I think Boris makes a really good point. We have an extensive program of interpreters primarily in Spanish. Mandarin is, I think, our second most common language that we have interpreters for. I don't even know. We have dozens and dozens of interpreters, and we have them available. But it is a challenge, to find at the right time an interpreter that's available for a specific rare language. We also use telephonic interpreters when we don't have somebody on staff that speaks that language. So we use a combination. But yeah, I mean, it just points out to how difficult these communications can be, and how we really have to be persistent and innovative in terms of how we get our points across.
It's so hard. I've been involved in several conversations with patients using video conference interpreters, and I think they do a great job. But I keep thinking to myself, I wonder what the patient is taking away from this, and how much sort of probing should I be doing? And to Emmanuel's issue, how comfortable are they sharing concerns and questions? It can be very, very difficult. So we've got about 8 minutes left. I'd love for folks, let's get those fingers flying, and spend about 5 minutes with strategies based on what you've heard that you can start using today to improve the way your CRP works for historically marginalized patients. What are some of the strategies that are coming to folks' minds? Being more proactive. It's incredibly important. And it's easy. I have not run across anyone working in the CRP space who has said to me, Tom, I've got some extra time on my hands. What can I do? Do you have something interesting I can work on? Everyone's like at 130, 150%. And it makes that extra proactivity, I think, especially hard to summon. We've had patients at our organization where it is difficult to figure out, how do we physically reach this person? They don't have a phone. We've reached out to a shelter where they've been, but we have no way of contacting them and knowing sort of a relative of what Stefan said of when is enough enough. So Liz, sometimes there's a trusted family advisor or spokesperson that they want included in the conversation, and asking that question and trying to meet that need is great. Asking if they related, Emma, asking if they need family and other supportive contacts to attend if appropriate. There have been some really good work done at Harborview with cultural interpreters who are different from language interpreters, but there are folks who are skilled not only in the language communication, but understanding the culture of that particular individual, and trying to make sure the engagement is happening in the most culturally competent way. What other strategies are folks thinking about? Stefan or Emmanuel, if you don't mind me asking, in these hypothetical cases, how did you approach the issue of attorney representation when it came to resolution with these patients? Were they represented, unrepresented? How did that issue play out?
Well, if a patient is represented, we will still meet back with them. If they want the attorney to be present at the meeting, we ask that the attorney can attend and listen, but not speak, which is difficult for an attorney, I know. But and we would also have representation for ourselves and the clinical staff that's involved. But we still try to have that meeting, even if the patient is represented. And when asked, if the patient or the patient's family asks about representation, we tell them that it's their right. If they want to get represented, they certainly can.
Thank you. Emmanuel, did the issue of patient representation come up in hypothetical case one?
No, it did not come up. We do let them know that if they want to bring an attorney with them to represent them, they can do that. And we have a process of engaging the patients and families when they have representation.
So this is going to be an area over the next couple of years in the CRP space that I think will continue to develop, and really understanding what are best practices around patient representation. And it may be through an attorney, it may not be through an attorney, but especially for historically marginalized patients who are vulnerable in all sorts of ways, really trying to be proactive around ensuring they understand the process and are able to advocate for their rights is, I think, important. Amber talks about having multiple interpreter services available to meet to the patient. That is a great suggestion. Meryl's question about how is it determined how much will be offered is something we can work on with you offline, Meryl, if you would like. Let's just move to the next slide before we run out of time. So this is a really complex topic. What are some of the lessons learned that people are taking away from what we've talked about so far? Barb Pelletreau, definitely works best if the patient and the family had a great experience at the facility prior to the event occurring. Barb is right, and this is another area that the CRP field will be building on, is trying to improve the communication before an event creates a platform, a bond of trust that makes this much, much easier. So what are people taking away? Key lessons learned while folks are thinking. Emmanuel, if there's one thing that you'd like people to take away from this webinar, what would that be?
To be one thing, but one is when you working with historically marginalized patient populations, especially if that's that case, identifying it at the beginning is a good idea because it gives you some level of mental effort that will be required, because you typically tell them try twice and leave a contact and say, if you have any questions, please reach out. Some of these cases don't fall in that bucket. So knowing the family at the beginning and trying to put in more time to understand the situation is helpful, not just in the beginning, but also at the end of the CRP process.
Thank you so much. And Stefan, is there one thing you really want to make sure that all the folks here take away from what we've discussed so far?
So I think that the two cases that we spoke about today and the comments and questions that we had show how hard this work is. That's, it's not for the people who are looking for the easy way out. I mean, I think that what you need to do is keep the patient and their needs at the center of the discussion, and always be doing your best to try to address their specific needs based on their culture or their other, the other factors that make them a marginalized patient to begin with. These patients are not going to self-identify. They're not going to identify when a problem occurs. We have to be the ones to identify when there's been a lapse in care. I think we have to be proactive in that way for sure.
So CRPs are programs that have vulnerabilities, and vulnerabilities often express themselves in situations like this, when we're caring for historically marginalized patients who are more likely to experience problems and less likely to experience a satisfactory CRP response. So be thinking carefully about, at your organizations, are you doing as much as you can to make sure that your CRP is highly reliable. You have mechanisms in place to identify historically marginalized patients who have had a harm event and proactively reach out and support them. I really want to thank all of the work group members for the PACT Innovation and Leadership Network on DEI and CRP, Renee, Annie, Emmanuel, who you've met, Stephanie, Stefan, who you've met. We welcome your feedback. Emmanuel and Stefan are amazing resources on this topic. I know they would be pleased to chat with any of you and share some of their practical experiences working through this, and expect much, much more to come as we strive to make our CRPs work for each and every patient, each and every time. So thanks so much for joining us, and we look forward to future webinars. Bye-bye.
Thanks, everyone.
Thank you. Bye.
Thank you, Tom. Thank you, Nicole. Thank you, Emmanuel.
Thank you, everyone. We'll see you next time.